Well, good evening, everyone. I have about 6:01, and I'd like to go ahead and convene this meeting. So first, we'll start off as we usually do with the Pledge of Allegiance. Ask everybody to stand, please. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Just for a moment, I usually ask our commissioner rep to give the invocation. I don't see him here today, so I will do it myself. Heavenly Father, we thank you, Lord, as you give us this another opportunity, Lord, to convene this meeting of the Human Services Board of Union County. Lord, help us to keep our minds straight, that we might be able to do the right things and make the right decisions, and staff may be able to make the right decisions to help become a safety net for those who are economically deprived, Lord, in this community, Lord, and also socially deprived, Lord. We thank you, Lord, in advance, Lord. In Jesus Christ's name, amen. So we usually have name tags, and I don't see Carla here. So I don't know what happened to the name tag. So I'm going to ask everybody if they would just go around the room and introduce themselves, so everybody will know everybody, at least maybe be a little bit more familiar with one another. I'll start first. My name is Earl Ford, and I was nominated not too long ago, I believe, to be the board chair. I used to work in human services, and I'm happy to be over here to serve. I live in Waxhaw, North Carolina. Thank you. Let's start that in.
Hi, I'm Lisa Kerner. I'm an employee of the City of Monroe, but I'm here as just a general person, citizen.
Hey, good evening, y'all. I'm Kirsten Aludis. I am on faculty over at the UNC School of Government, and I'm here today to talk to y'all about public health and consolidated board governance. Spicy, I know, you're definitely.
I'm Dennis Joyner, the Public Health Director.
Jeff Broadway, Veterinarian Public Health.
Tracy Colley, Environmental Health Director.
Stephanie Starr, Director, Community Support and Outreach.
Hi, I'm Wendy Sellers. I am probably one of the newer board members here today. I'm the founding director of the social work program at Wingate University. We're starting with a graduate program, and our first day was today.
Go Bulldogs. Ashley Lance, Director of Social Services. I'm Heather Weiss, and I'm a veterinarian.
I'm Susan Marciniak. I'm a new person to the board, general person, or I don't know what exactly my role is, but it's the same as you.
I'm Jill James. I'm an RN, and I'm newly appointed as well.
Craig Colash, general surgeon, weight loss surgeries and specialties. I'm the physician, I guess, and I've been a part of the board for 5 minutes.
Hi, Michelle Marcano, Director of Veteran Services.
Hi, I'm Alexis Sable. I'm a social worker in our public health department, here with Dr. Tran to present on our child health behavioral health program initiative.
I'm Dorothy Tran. I am the physician who works here in the child health clinic and family planning clinic department.
I'm Meg Harkins. I'm the engineering member, and I'm late. And I'm UNC Charlotte faculty member.
Good evening, I'm Janet Payne. I'm the director of the Human Services Agency.
Teresa Torres, Director of Transportation.
Thank you. It's so nice to have all of you here, and thankful that everyone wants to try to contribute to this board and make Union County a better place. And so now I'm going to ask, I think everyone may have had a chance to review the minutes. Well, it's been a long time since July until Ashley, I was here last month, but I forgot we did not have a meeting last month. But so to review the July minutes, hopefully everyone has had a chance, and if you've had a chance to, any board members had a chance to review those minutes, I would ask for a motion to approve the minutes for July. June, okay, I'm sorry, I thought that would be June, not July. July was when we were off. Seems like time goes by so fast. So can we have a motion to approve the June minutes?
Motion.
Okay, we have a motion.
I actually did look at it.
We have a motion. Second, so the motion carries. Minutes are approved. So, before we get started into the meeting, I see we have a lot of pretty intensive presentation. I want to ask Janet, our executive director, does she have anything that she wants to start off with? Oh, yes, okay. Yes. Can we have a motion to approve the minutes, or the agenda rather, for today's meeting?
Motion.
Got one motion.
Second.
And second. All in favor say aye. Aye. Opposed say no. Okay, agenda has been approved. So now I'll refer to Janet.
Thank you. Greg and Meg are a good tag team there for the motions. So I did not actually have an agenda item, but do have just one update that I want to provide and ask you all for your consideration, just for general broad endorsement, I guess, for lack of a better word. So Dr. Bott has offered us a great opportunity to partner with Union Family Eye, and that will be to provide vision care for children who are served by the Human Services Agency. I think I may have briefly mentioned that at a prior meeting, but I know a lot of you obviously weren't there, so that's something that we are excited about, and that would be for kids in our care that may or may not have adequate insurance. They may have no insurance, and it would include at no cost to them an exam as well as the frames and glasses. And so that's a wonderful opportunity that he is presenting, and it's something I know I wish he were here, because I know it's a passion that he has in terms of providing care to the community in a way that he can give back. So it's something that I just wanted to make sure that I shared with you all. It's for all age ranges. If they are Spanish speaking, they will need to bring an interpreter with them. It could be a family member or a friend, but there's no issues other than that. They do take Medicaid PHPs for clients that are insured, so from that perspective, that opens up the opportunity to a number of people. And internally, they can either just call his office, or we actually have a referral form, and so our intent is for staff internally to utilize a super simple referral form with just a couple of fields in it that will then email the client being referred directions to Union Family Eye, what number to call to set up their appointment and that sort of thing, and then it will email Dr. Bott as well, so that they'll have a record of that, and then obviously we'll have a record of all of any of the referrals that happen to be sent over to him. And so don't really need any action taken for you all, but because this is a partnership with the community and something that matters from a public health perspective, I want to make sure that we do get, well, first of all, inform you all, and then also get any feedback that you might have in terms of support of this or concerns about it.
It sounds like a great thing. They're helping children. It sounds like a great thing from my perspective. Thank you for that information. Anybody else have any comments?
Thank you. We have a heavy agenda tonight, so
yes.
I'll say keep rolling.
All right. So it would be now, if I'm getting my synchronization correct, would be division reports now. Okay, let's go.
So the first report will be a child health behavioral health program, and we have Alexis Fall and Dr. Dorothy Tran, who are here to present to you all to give an overview of that. And the action that we're requesting for you there is simply an indication of support of the child health behavioral health program. And so I'm going to let them describe the program to you.
Well, good evening, everybody. Again, I am Dorothy, and I'm presenting with Alexis today to talk about a new initiative that we started in our child health clinic. It is called Child Health Behavioral Health, and it's essentially an integrated mental health care utilizing a model called collaborative care. I do want to mention this has been an effort of many people, and so we're really grateful for a wonderful team and leadership who have supported us through this entire process. This began back in November of 2023, and we have been given the opportunity to implement, and has gone so smoothly, and we have already seen 9 patients, and we have 14 total scheduled. So a little bit more information about this as we go on. Before I do want to continue, I do want to acknowledge that we all come from different experiences, and those experiences can affect how we react to certain information. So I will be talking about different statistics regarding mental health, which will include suicide. So if any of you need to step out or to talk to somebody afterwards, please do. So as you all know, mental health is a public health issue. This is a great quote that I like to read. I know there's a lot of words on the slide, but I think it helps us give a frame of reference in terms of why mental health is so important. Providing for and supporting good mental health is a public health issue, just like assuring the quality of drinking water or preventing and managing infectious diseases. Communities prosper when the mental health needs of community members are met. Unaddressed mental health issues can have a negative influence on homelessness, poverty, employment, safety, and the local economy. For young people, mental health is influenced by a web of interactions among the young person, the family, child service systems, school, health, foster care, and the neighborhoods and communities in which they live. So I do want to go over some statistics regarding to the impact of mental health, and specifically the impact of mental health in young adolescents. We know that mental health conditions start early. Half of all mental health disorders show signs before the age of 14, and 3/4 of mental health disorders begin before the age of 24. And unfortunately, this gap in care significantly impacts high school graduation rates, life duration, and tobacco and alcohol usage. Additionally, half of children and adolescents with mental health conditions receive the treatment they need, only half. And with all of that, mental health costs have increased significantly. Compared to 2009, we were spending about $171 billion in the United States, and 2020 is $280 billion. And the research is still coming out for post-COVID mental health cost. But the good news is that if we do treat well and we treat mental health, we see improvements. We see less emergency room visits, less hospital stays, less periods of incarceration, and substance use is decreased. Specific to North Carolina, we also know that 1 in 5 North Carolina high school students have reported seriously considering attempting suicide. 1 in 5, that is a large number. And unfortunately, most of these kids do not, like we said, have to receive the care they need. And then in communities with marginalized communities face even more significant barriers. Adolescents who are Latinx or African American are 1.5 to 3 times more likely to not have their mental health needs met. On top of that, we just don't have enough workforce, just not enough psychiatrists, not enough, honestly, PCPs to be able to take care of our young children. And there's been research about PCPs in general too, that are we actually equipped to take care of these young kids? And actually,
What's the acronym you're using? PP?
Oh, PCPs, primary care provider. Okay. Yeah, thank you for asking. Thank you. Pediatricians, family docs. And they look at us and say, hey, are you guys giving adequate care? Unfortunately not. Our training has not been up to par. You know, a lot of us, we're taught to refer out for kids just because of the complexity. So now there's been a lot of push to teach PCPs on how to manage medications in the clinical setting. Also, North Carolina faces a shortage of mental health professionals. All but 4 counties have a shortage of mental health. Oh, okay. Thank you. Yeah. All but 4 counties actually all but 4 counties face a shortage of mental health professionals. So we see Union County there. It looks like a little arrow to me. Harvard County does have a shortage of mental health providers. But unfortunately, most of these providers that we do have in the county don't accept Medicaid or see uninsured kiddos.
I should ask you, I know you had the numbers, 1 in 5 high school students are reportedly seriously considering attempting suicide. How about, do you have any numbers for Union County specifically?
We don't. That's a great question. So there is a database that we all can access, which looks at how many child adolescent psychiatrists specifically to Union County. So we don't know the statistics behind the students, but we have a number of psychiatrists. And we've got 10, which was a lot higher than I expected when I looked this up. But like I said before, most of these clinicians do not accept our children's insurances. Some of them are private. And if they are accepting our insurance, the wait list can be up to 3 to 6 months. So, that is not all doom. We have been excited to talk about something called collaborative care, and here we're going to call it child health, behavioral health, because we don't want to confuse it with collaborative that the county has been doing with DSS, which is also wonderful work too. But back in November, we were given this opportunity to implement this new model, and essentially is integrating psychiatric care into our clinic. And we were one of the 9 primary care practices that were given this opportunity in the state. So just to start off with, to kind of give the overview, there is a video, a short one.
Millions of Americans struggle with mental health and substance use issues each year. But quality treatment can be difficult and expensive to access, often leading to a lot of unnecessary medical expenses if left unaddressed. We know that when accessible and done right, psychiatric treatment works. Many patients with mental health and substance use concerns talk to their primary care providers, or PCP, first. PCPs traditionally have had 2 choices: treat the issue themselves, or try to refer the patient to a mental health provider, like a psychiatrist. Unfortunately, medical providers sometimes don't know how to respond or how to help patients access quality mental health care. In part, that's because there simply aren't enough mental health providers to meet the need of all the referrals. Wouldn't it be great if there was a way to get people seen that was timely, effective, affordable, less stigmatizing for patients, less costly for healthcare systems, and ensured access to psychiatrists who play a central role in providing effective, quality treatment? There is. The collaborative care model is a way to provide psychiatric services in the primary care setting. The collaborative care model has a rich body of scientific evidence supporting its efficacy. How does it work? The cornerstone of the model is a behavioral health care manager, a mental health professional who practices right in the clinic with the primary care team, ensuring accessibility. This care manager works directly with a consulting psychiatrist who provides the expertise to keep treatment on track and who is available to offer support on cases that need extra help. The model uses procedures for assessment and treatment that have been proven to work. It's an organized approach that ensures patients receive the most effective care and no one falls through the cracks. Treatment can include focused talking therapies and medication when indicated that's prescribed by the PCP and overseen by the consulting psychiatrist. This model makes quality mental health care more accessible to more individuals across the country. Seem too good to be true? Collaborative care is happening right now all over the country, and it's reimbursable by insurance. Psychiatric treatment works, and the collaborative care model helps more people access it. With this model, providers can focus on what they do best, help people get better. Interested in learning more? Visit psychiatry.org/collaborate for more information.
Any questions on that? We'll explain a little more. So they had briefly showed that little graph or the image of the different team members in the collaborative care model. The first is the patient and the family. If you look at the next slide, right there, family caregivers are at the center. You see the primary care provider, which is would be me, and then we have a special role, so in a psychiatric consultant, and we have a special role, which is the behavioral health care manager. And I will pass this over to Alexis, who is our behavioral health care manager.
Thank you. Yes, so kind of also just to sum up a little bit with the video and then talking about going across the United States, the collaborative care model was developed out of the University of Washington, actually in the 1990s, and has made its way across the U.S. to North Carolina. And it does have a lot of evidence base behind it to help us, which gave us the encouragement to move forward with this model and to integrate it into our pediatric setting here in Union County Child Health Clinic. And so it does include this unique role of the behavioral health care manager, which is the role that I will take on, or have taken on, which means that I will partner with the primary care provider in the clinic and the psychiatric consultant to develop a treatment plan for the patients that are seen in our office, which can include medication if indicated, but also includes brief strategic evidence-based behavior interventions. And so the idea behind it is that the patient's able to come to a place that they're familiar with. They already know their primary care provider. Many of our patients we've been seeing since birth. And a place that they know how to navigate, how to get to, and be able to get that mental health care that, as we talked about before, can be really difficult to access in the community for one reason or another. There are lots of barriers that end up keeping people from getting the care that they need. Another piece of the model is the registry. So the registry is basically a fancy Excel spreadsheet that helps us to track our data. So it helps us to have an organized way to have all of our patients in one place and track their treatment progress so that the psychiatric consultant has access to it and our primary care provider to be able to see which patients are improving or not improving, and that way we can address those needs depending on what's going on for them. So a little bit more about the treatment. This program is specifically for the patients that are seen in our child health clinic, so it is not going to be something that we're accepting outside referrals for. It's not necessarily going to be its own outpatient clinic. So the children that are going to be eligible for the child health behavioral health program have to be established with the child health clinic as our primary care patients to start. Once we identify kids that may have some needs, those kids are going to be between the ages of 8 to 21. We have, as our regular clinic process, a way of screening through validated measuring tools, and those are some examples up there. So the PHQ-A screens for depression, the SCARED screens for anxiety, as well as the GAD-7, and the short mood and feelings questionnaire and the Vanderbilt will assess for some other behavioral types of needs. Specifically, the Vanderbilt looks at ADHD. And so once we screen our patients using these tools, it helps us to identify which patients would be appropriate for the child health behavioral health program. And then we would schedule an intake. The behavioral health care manager, which is myself, then meets with the patient every other week for about 6 to 9 months, no more than 12 months. And the behavioral health care manager is also meeting weekly with the psychiatric consultant to discuss our treatment and medication recommendations if indicated, and relaying those to the primary care provider. So it's really this team model that we're all working together to make sure that the needs of the patient are addressed. And the treatment progress is monitored with the outcomes tracked, again, using those validated measuring tools. So why is this so helpful? We've talked a lot about the pediatric mental health crisis, so this is another way to aid in addressing that. We do have a lot of really great work already happening in Union County. We do have community providers that come with some barriers. We do have our DSS collaborative, but the reality is that we still have kids and families that need support and help. A lot of the places that do exist have wait lists or are at capacity, so there's unfortunately many more people that are still looking for help in one way or another. A really great thing is that this program is reimbursable through Medicaid, and so the ability to receive that reimbursement can also help perhaps support the expansion of the program. It also helps to offload some mood recheck appointments. So we do have situations where patients will come in and ask for a sick appointment and we don't have an appointment available for them. So if there's a way that we can pull some of these appointments off the regular clinic schedule and onto our child health behavioral health schedule, that might open up some appointments for kids that are otherwise having to go to urgent care or something like that. It also can offload some of our mental health related referrals. So we have referral coordinators that assist with getting patients connected to any referral that they need in the community. So whether that's physical therapy or a neurologist or a cardiologist, mental health is one of those. As a child health social worker, I do try to help with that, but it can also, kind of take some of that burden off our referral coordinators as well. And then like we were talking about, Dr. Tran had mentioned that with primary care doctors, the training that is received is not always focused on medication for behavioral health conditions. So having that psychiatric consultant as somebody that we can go to talk through our patient's needs with and be able to receive guidance and advice from is just really invaluable and kind of, is really what makes it possible for us to implement this program into our clinic. So funding. We have been incredibly lucky to get matched with a few different organizations that have made the implementation of this program possible. The first is NCPAL. NCPAL stands for North Carolina Psychiatric Assistance Line. They received funding from North Carolina State to allow pilot programs for 9 practices. And a part of their pilot program is that they match us with a psychiatric consultant, and those services are provided to us pro bono for at least 1 year. So we've been matched with a psychiatric consultant from Duke University. Her name is Dr. Courtney McMickens. She is brilliant. She went to Harvard University, so we are just so excited to get to learn from her, and it's awesome. And then the other thing that NCPAL helps as a part of their pilot program is providing clinical training. So they've provided clinical training to myself and to Dr. Tran as it relates to the treatment modalities that we use within the program. AHEC, which stands for Area Health Education Center. They have practice support coaches, so we have 2 people assigned to us from AHEC that help with kind of the more like administrative and business implementation piece of the program and the model, particularly around billing and financial modeling. And then we have CCNC and Ames Community Care of North Carolina has received funding from the state to then give us access to the registry that I was talking about before that helps us to track our patient data, also pro bono for at least 3 to 5 years. So between these 3 supports, we are able to implement the program and possibly have some other grant funding in the future to be able to even further support our program. And we launched. We launched on August 1st. We've seen 9 patients. We have 14 in total so far, with quite a few that are possible patients. So we have a 100% show rate so far too, which has also been very exciting. And so it's been great so far. Questions?
I have a question.
Yes, ma'am.
With regard to our dual diagnosed youth, like with IDD, you might have covered that before I came in, but what is the limitation on that for participation?
Yeah, that is a really, really great question. So when we were on the treatment slide, it kind of briefly talked about mild and moderate screenings. So that means that if we have patients that come in and the screenings indicate that they have more severe needs, those are patients that we are going to refer out. So those are patients that have severe depression, severe anxiety, maybe some dual diagnosis. So whether that's bipolar, also intellectual and developmental disabilities, and substance use. So if a patient has any of those conditions going on for them, they are going to be referred out to a more intensive programming or a more specialized programming than the child health behavioral health program would be able to provide.
I do want to mention that although Medicaid is reimbursing for the work that we're doing, we are providing this for our uninsured patients too.
I just want to add one other thing. Our goal is to be able to make this be long-term, so we're really excited. This is technically a pilot program at this juncture, but we're going to not only assess the results from a patient perspective, but also we'll know after a couple of months what the revenue looks like, and we think and are hopeful if our models play themselves out that actually this will be something that will be self-sustaining. And obviously the NC-PAL funding is short-term, at least at this point, and so it's something that it's beneficial even if we can only do it short-term, but our hope is that it will be something that can be ongoing.
So that kind of answers the question. So I was going to ask a question about what happens after 1 year. So it's going to just be reassessed, and if it can support itself, it will be continued?
So
because the 1 year, like the pro bono thing was just for 1 year. I was like, okay, that's
right.
spectacular, but 1 year.
So our budget season begins December timeframe, and we have to submit them the request typically by February timeframe. So we should have at least 6 months worth of data at that point, and should know what the business model looks like effectively from a monetary perspective, and we'll make budget requests based off of both, again, the patient results that we know to date, obviously, and then those monetary results that we know as well. And depending on the efficacy, which we anticipate to be really high, we will probably make the request regardless of the whether or not the funding can be fully covered by the Medicaid reimbursement. But that obviously is a consideration from a fiscal perspective.
One more question. What about bilingual community members?
Yeah, so we are working with patients, parents, families that are Spanish speaking and English speaking. We have a VRI, so an iPad that helps with the translation for the parents. Mostly so far, the children have all been English speaking, but we are planning to meet with children that are Spanish speaking as well.
Does the psychiatrist you have from Duke, do they interact directly with the patients also, or she directs with, like, you bring the patient, present the patient to them, and then she helps you with the treatment?
Yeah, exactly. So we meet on a weekly basis and we go over every patient I've seen that week, and then gives recommendations from there that I then assign to Dr. Tran for her to review. It is possible, like let's say that there's something, rare or unique going on for that patient that she might request to do that, but 99.9% of the time it's going to be me presenting to her about the work that we're doing.
With regard to that, I think it's important to point out what y'all said about the behavioral health crisis that we're, seeing. I know that's the population that I usually support in our community. Most days, for example, Atrium Levine right now, who gets a lot of our spillover, who has the spillover of behavioral health billings leak, currently has 23 kids waiting on beds, right? So they're in the medical hospital waiting on beds. That's the level of the support needs. And also on the NC-PAL, even after the funding, y'all would still be able to get the consult for free, correct? Like with that, I think that's important for everybody to know too, so toward the sustainability.
Yeah,
the reason I asked about the Spanish speaking or bilingual is because that's additional funding sources for additional grants that just released from SAMHSA this week.
Oh, well that's great to know. Thank you so much. The other, really I think important thing to kind of point out is that my role before transitioning into the behavioral health care manager was a title child health social worker. And so we also want to be thoughtful that in implementing this program, we're not dropping the needs of everything that the child health social worker did. So we're in talks with Dr. Sellers over there about getting a social work intern and just kind of being thoughtful about what are the ways that we can make sure that even though we're implementing this program, that the needs that were being addressed before are not going unaddressed, including if we need to refer out to the community if a patient's needs are higher than what we can meet.
So is the behavior health care manager, which is your role, is that always a social worker?
Yeah, that's also a really great question. It does not have to be. It can be many different professions. The person just would have to have specialized training in behavioral health care managing, which is available through the AIM Center out of the University of Washington, which is one that I've completed. As a social worker, under my social work licensing board, I would need to be a clinical social worker for this role to be in adherence with the social work requirements. But it can be other professions like a licensed clinical mental health counselor. There are some practices that even have RNs that are in this role. So it just kind of depends.
It kind of reminds me of like the physician assistant or nurse practitioner role model of delivering care. You know?
Oh, yeah.
Where you don't always see the doctor, but they have that reporting relationship with the physician.
Mm-hmm.
What does that look like with regard to pharmaceutical and prescriptions?
So every patient in the registry is going to be consulted with a psychiatrist, and she would make recommendations, and those recommendations actually come to me, and I have to agree with the recommendation. And then if I agree with the assessment, then I will put the prescription under my name. It's actually, our clinic works very collaboratively. We have 3 providers, but we share our panel. We know every family very well. And so it works, if I have a disagreement or I'm not, any more questions, there's openness in it. So we can always go back and psychiatric consult, like why choose medications, can we try something different? But so we'll send them to the pharmacy. We are working with our uninsured patients to look at lower cost medications. That's kind of where our barriers are right now, especially for ADHD medications. Thankfully, the other medications like SSRIs are relatively affordable, but still finding a barrier to ADHD medications.
Any more questions from anyone? Any board members have any questions? Or any other staff?
I do have one last question.
Sure.
On your tracking spreadsheet, and when you're going through this, are you going to be keeping the social determinants of health as a factor within that? So, it could give guidance to the group for other things to look at.
Yeah, that's a great question. So not in the registry that comes out of the AIM Center, because that's specifically to look at those validated measuring tools, but we do track that in our electronic health record, and every family that comes in for a physical is given the social determinants of health questionnaire, and so we track it that way, a regular clinic practice.
Any more questions from anyone? Well, it looks like there's a serious demand for this, and I know the board appreciates this. I think I'm speaking for the board. We appreciate this support that we're getting from this team. It seems like it's certainly a much-needed service, and I hope that funding will continue for it. And on that behalf, the board, I hope I'm speaking for the board again, that we have a letter just of support for you guys on this. Dennis?
Earl, I was just going to say, it would be appreciative if there could be a motion or something to just indicate the board's support of this initiative. That would help us as it relates to moving forward, looking at other funding sources and that kind of thing. I did want to point out too that the fact that we're one of 9 initial counties, we're the only public health department who's doing this across North Carolina right now. It's public health has been charged with a lot of things, but one of them has been looking at ways to integrate behavioral health in ways that make sense in terms of the care that's provided. And this is a unique opportunity for us to get into that work in a way that integrates with vulnerable population groups that we are already serving. So it's an exciting time, I think, for us to embark on this. So I would just say if you could indicate a motion of support, that would be great.
I'd love to make a motion of support for this.
Second.
Okay, all in favor, say aye.
Aye.
Aye, any nays? All right, Mrs. Carey, we support. Well, thank you so much. And now, this is, I guess, perfect timing, since we have so many new board members, that we're going to have this, I'm just excited myself to hear about this Consolidated Human Services Board training, Part 1. So whoever wants to start off with that, that would be great.
I'll just start the introduction of Kirsten Laludis. How did I do? Okay, very good. She's with the School of Government, as she introduced herself earlier, but this is one of a two-part training. We're going to also have training in September's meeting as well, which will look at some more of the social work, social services side of responsibilities of Consolidated Human Services Boards. But tonight, the focus is on sort of those boards of health statutory authorities and responsibilities.
I'm so pleased that you're excited about this. This, and when I teach about HIPAA, folks are like, oh gosh. So I'm actually going to stand up, if that's okay, and maybe go to the other side of the room. I like to kind of move around a tiny bit. So before I get started, just want to say thank y'all for having me here tonight, and also just thank you for what you do. Local governance, local public health, local social services are so extraordinarily important. And I know it takes a lot of your time and energy to be either kind of directly on the front lines doing that work or to be serving on this board. So thank you so much for all you do. We're really appreciative. So this is me. I'm Kirsten Laludis. I am an attorney by training, but my first love is really public health. And I'm currently living the dream over at the School of Government, getting to do public health law. So I offer trainings and advising on topics like this, Board of Health governance, consolidated board governance, but also work in areas like HIPAA, communicable disease control, child and adolescent health, minors consent, support for pregnant young people, all sorts of really fun things, which I say just because at the School of Government, we are here for you. We are typically a free resource. We can't provide legal advice, so we can't say this is what you should do based on the very unique facts of your situation, but we can say this is what the law says, and these are your options. And you're welcome to call us, email us any time of day or night. About a third of all of our jobs is dedicated to answering those calls and emails. So please do feel like you can reach out to me or to my colleague Christy Nicodem, who I believe is going to come down in September and talk more about social services. One last piece about the School of Government is that we are really committed to being responsive, nonpartisan, and policy neutral. For us, responsive means that we care about what you care about. So for example, I personally love doing adolescent health. I love minors consent. I'd talk about that all day if I possibly could. But if you tell me that, half of North Carolina really needs help navigating the new laws around septic tank inspections, that is where I will focus my time. Okay? That is where I have focused a lot of my time. So we want to be responsive. We are here for you. So let us know what you need. We are nonpartisan and also policy neutral. And so that means that if one of your staff at the health department calls and asks me a question, and then a local reporter asks me the same question a few days later, and then a commissioner calls and has the same question, in theory, I should be giving everybody the exact same answer, right? Because I'm explaining what the law is, not sharing Kirsten's thoughts and feelings about what would be a good idea. So here's where we're headed today. We've got a lot to cover. We're going to start first by just talking about public health in North Carolina, just to give you a kind of lay of the land. We'll then talk a little bit about Consolidated Human Services Agencies and CHS boards, so Consolidated Human Services boards, the powers, duties, and responsibilities that those boards have related to public health, and how they also get divvied up amongst some other players, including your local health director and your county commissioners. And then last but not least, some additional legal considerations for your board, so things like public records. open meetings, ethics, liability. The really, really fun, exciting stuff is what we're going to hit last. So a few quick notes. We are really just going to talk today about Consolidated Human Services agencies and their boards and the public health piece of that. So we're not going to talk, for example, about district boards of health and how they're really different from y'all. We just don't have enough time and space to do that. We do have some new books that are coming out in the school government soon. We just had one published by Chrissy Nicodem. It's a legal guide for social services boards. That's the first in a 3-book series. So we have another one that's coming out that's just for the public health side of governance, and then a special book just for consolidated agencies and their boards. So those should be out, we hope, in 2025. And again, if you have a question later, you're always welcome to email me or give me a call. Can folks hear me okay if I don't use the microphone? I want to be sensitive to the fact that
If you could use it just because we're also online.
Oh, we're also online. Oh, my goodness. Okay. Well, hello, everybody online. Okay, great. I will happily use this then. I like to gesticulate a lot, so sometimes the mic ends up like over here. One quick note, this is our alphabet soup. We're going to use a lot of acronyms today, and I apologize. That seems to be a thing in the public health and social services world. We love our acronyms. Here I've got some of them laid out for you, and I will do my best every now and then to pause and kind of remind folks what these stand for. But I'll let you review those real quick. And I want to say one more thing about the term Board of Health, or BOH, which I'm going to use a lot tonight. So a Board of Health is the governing board for a local health department in North Carolina. And that can look like a lot of things. That can be a district Board of Health. That could be the Board of Health that just serves one county standalone local health department. It could be your consolidated board for your Consolidated Human Services agency. It can be so many different things. So sometimes when I say Board of Health, I mean Board of Health in this big, general way. Other times when I say Board of Health, I mean y'all. I mean the Consolidated Human Services Board acting as the Board of Health, right? Because you inherit all the powers and duties of a Board of Health. And so we'll be talking about them in kind of 2 different contexts tonight. If you ever, just for fun, want to read some statutes, this is what I do for fun on the weekend. This is the best one for you. It's 153A-77. It's the bread and butter for Consolidated Human Services agencies. It really lays out kind of how they're supposed to be organized and explains what public health and social services powers go where. So let's talk first about public health in North Carolina. We have what's called a decentralized system in this state. So that means that we have a state public health agency. It's the North Carolina Department of Health and Human Services, or DHHS, and below that is the Division of Public Health. So they're really responsible for public health on the statewide level. But then we have local public health agencies in every single county in North Carolina, all 100 counties. They're going to be served by one of these agencies. These folks are really the boots on the ground. So when you kind of compare what the state does to what locals do, for example, the state's oftentimes kind of doing state level policy, big programmatic stuff, maybe delivering funding to the locals. The locals are the ones who are talking to patients, for example, going out and inspecting those restaurants. So it looks a little bit different at the state and local level. Another really important piece of our decentralized system is that these are legally distinct entities, right? So there is a really, really strong funding relationship between your state and local public health agencies, but you are legally separate, which means that DHHS is oftentimes passing down federal or state dollars to the locals and saying, this is how you're supposed to use it, but they can't exactly tell you what to do, right? Because you are legally distinct, and so there is some autonomy when you're serving your own community. We have a statute. It's 130A-34. 130A is the chapter of our statutes that's dedicated entirely to public health. And it says that every county in the state has to provide public health services. And there are ways you can do that. You can either have your county health department, which again is your standalone local health department. You can have what y'all have here in Union County, a consolidated human services agency that includes public health, a district health department, which is where sometimes some smaller counties might come together and form one large health department to serve a whole region, or you can contract with the state for public health services. So every single county has to be served by a local health department, and in turn, every single local health department has to have some type of board of health, and also a health director. So again, these are kind of your options in North Carolina for setting up your local public health governance. The old school model, what we really started with, was the county health department, right? That was your standalone health department, wasn't consolidated, it was kind of its own entity, and that had a county board of health. You also have district health departments and district boards of health, Consolidated Human Services Agencies, your CHS board, and then these two kind of unicorns here. You have public hospital authorities and public hospital authority boards. We only have one county in North Carolina that uses this model. Does anybody know which one it is? I mean, is it cheating if you answer? Cabarrus, who is it?
Cabarrus.
It's Cabarrus, yes. Cabarrus is the only, good job, it's the only county in North Carolina that uses this model. And then our very last option, Public Health Authority. We actually don't have any counties that are using this model right now. We've had some folks try it, and then they've typically reverted back. So the work of local health departments, or LHDs. So again, I said earlier, LHDs are really your boots on the ground of public health. I do want to make one clarification here. It may not be necessary with this audience, but just to clarify that public health is not the same thing as healthcare, right? There's a lot of overlap, a lot of collaboration, a lot of intersection, but it's not quite the same thing as healthcare. Oftentimes healthcare is focused on individual patients and assessing their symptoms, their needs. Public health looks more at community health, right? Community well-being. And it's a really, really expansive field. So something that public health folks love to say is that public health really kind of works from cradle to grave, right? You're born in North Carolina. If you're born in a hospital, your little heel is pricked and some of your blood is taken to the state lab for public health and it's screened as part of our newborn screening program. Your birth is recorded by your local registrar, right? You grow up, you go to school, you get your childhood immunizations, and those might be administered by your local health department. Then maybe one day you decide you're gonna grow up and have kids of your own. You know, y'all wanna get a dog, little Rex. Rex is gonna get their rabies vaccine at the rabies clinic that is administered by your local health director. You guys as a family go out to eat every Tuesday night for Taco Tuesday, and the only reason you don't get food poisoning every week is because a registered environmental health specialist came through and inspected that restaurant. Right? And then as you get near the end of your life, you go to a nursing home, also inspected to make sure it's safe and sanitary by a registered environmental health specialist. And then eventually when you pass, that also gets registered in our vital record system, right? And those are just really quick examples, but public health touches our lives at so many different points and in so many different ways, and oftentimes it's really invisible work, especially if it's working well. So this work requires a lot of different professionals, a lot of health professionals, allied health professionals, folks who work in environmental health, your social workers, also folks in IT and security, especially as we collect more and more data in these fields. We have program evaluators, folks who are dedicated to emergency planning, and so much more. So I hit on some of these, but this is just kind of an example of what you might expect to see a local health department carrying out. And again, it's so much, and oftentimes it's work that's not seen, even though people are kind of constantly quietly working to keep our communities safe. The work that local health department staff do is really complex, not just in the actual nature of the work, but because it tends to be governed by a really, really complex framework of laws. So people who are doing this work oftentimes have to comply with North Carolina laws, but also federal laws, sometimes requirements for grants, maybe other contracts like the Consolidated agreement that you might have between the public health agency and the state. So in terms of North Carolina law, there are actually services that every single health department in North Carolina is required to provide. You do not have an option, you have to provide them. And then there are also, beyond that, certain services that you have to provide for free. So for example, STI testing, sickle cell testing, you have to offer those at no cost to the individual patient. For some of those, you can bill insurance, but you can't turn somebody away if they can't pay for them. There's also something called accreditation. Has anybody in here heard of accreditation? Okay. Accreditation, local health departments in North Carolina are all required to be accredited. So every 4 years, I believe, they have to go up and complete this really long, rigorous process that's meant to ensure that there's equity across the state in terms of health services at local health departments. Of course, there's also environmental health sanitation inspections, and those take place not just in restaurants, but also jails, lots of other facilities and spaces. So we have lots and lots of laws just at the state level. And then beyond that, there's federal law, right? There's things like HIPAA or 42 CFR Part 2 if you're offering substance use disorder treatment. If you have school nurses, they might have to comply with FERPA. So there's a whole lot going on here. And it can just be a real kind of web sometimes for folks to work through. Which I say in part because have sympathy for your agency employees, but also because we're here to help them wade through that if they have questions about it, because it can be really complex. So we're going to do a refresher, talking quickly about Consolidated Human Services Agencies and CHS boards before we start talking about the public health piece of y'all's role. So what even is a CSHA? So it's kind of a mega agency, right? It's a consolidation of 2 or more human services agencies. And our statute that allows us to do this consolidation, actually doesn't define human services agency. So typically you're taking agencies, you're putting them under one roof, one entity. Sometimes that happens in name only, right? And then sometimes you have counties that say, actually, we want to be in the same building, or we want to even share staff positions. We really want to truly consolidate. And it just looks different depending on the needs of your community and the governing boards. CHSAs are not required to include local public health, but almost every single one in the state does. You can also include other human services organizations and departments. For example, if you have aging services or veteran services, you could include those. One that we get a question about sometimes that Christy and I are still mulling over is animal services, because there's an argument that that is a human service in some ways, right? Especially with the rabies prevention piece. So folks are getting creative about how to bring together folks and partners under these models. One entity that you cannot include is your LME MCO, so your local mental health entity cannot be included in your CHSA. There's an exception for Mecklenburg. When you're talking about CHSAs, there are a lot of exceptions for Mecklenburg, but this is just one of them. So how do we get here? So before 2012, you could only have a CHSA in your county if you had a really big population. You had to have over 425,000 people. That changes in 2012. The General Assembly passes a new law that says actually any county that has an appointed county manager is allowed to create a CHSA. There's a process for doing it, specific timelines, certain notices that have to go out, but now any of y'all can do it. In Union County, my understanding is that y'all have been doing consolidation since 2014, I think. So y'all are some of the old school ones. At this point in time, we have more than 30 counties in the state that have chosen to take up this model. And we have some maps on the school government website, and I cannot claim credit for these. Christy is really the mastermind behind these maps. There's a link here if you'd like to check them out. They are interactive. They are sometimes a little bit behind, only because we use entirely self-reported data. So sometimes a county will switch its governance model, and then we hear a few months later and then make the change. But you can see here that a lot of the state is served by a consolidated human services agency. Again, there are a few things that make CHSAs unique, especially in the context of public health. So one is that the CHSA is actually led by a human services director. So this person is going to be hired and fired by the county manager with input and consent from their CHSS board. But if you were talking, for example, about a standalone county health department, the local health director would be the person who's in charge of that entity, and they would be hired and fired entirely by their local board. So it's a slightly different setup with CHSAs. Makes sense, of course, since that person here in this model is going to be hired and fired by the county manager. They also report directly to the county manager. They can hire their own staff, but again have to get buy-in and consent from the county manager, which is a little bit different from your county models, where typically it's just the local health director that has hire-fire authority for their own staff. And then we have this other piece here. So if the CHSS director does not meet the requirements for a local health director, they're supposed to appoint a local health director. And we have some requirements set out again in 130A, our statutes about public health. And there are certain experience and education requirements that you have to be the local health director. And we'll talk more about that in just a second. One other really big change, especially for staff, is that CHSA employees can end up being subject to county personnel policies. In fact, this is the default. So if you decide to consolidate, by default, all of your employees in public health and social services are going to switch from this system of being under the State Human Resources Act to being under your county personnel policies unless your Board of County Commissioners specifically chooses to go the opposite way. And one of the reasons that employees sometimes care about being under the SHRA is that the SHRA has a few more protections depending on what the county policies look like. But for example, it can be a little bit harder to terminate somebody's employment if you're under the SHRA. So sometimes counties make this shift. Folks end up under their county personnel policies and they're not super thrilled about that. So one thing I wanted to flag for y'all about the local health director. Before, I said that we have this statute that says the CHSS director has to appoint someone who meets the qualifications of a local health director if they themselves don't meet those requirements. What was not clear in the past was whether or not you just had to appoint someone or appoint that person and then delegate all the powers and duties of health director to them. I think some folks would say, well, logically, you appoint somebody as health director, they have the qualifications to be health director, so you delegate the related powers and duties, like the ability to issue quarantine and isolation orders. Other folks said, no, the statute is silent on that, right? And if the General Assembly meant to do that, they would have been specific. So they've actually come back, and we have a new session law that just came out this year that says that the CHS director must appoint someone who meets these requirements, and that person is going to serve as the local health director. So they've made it more clear now. When you appoint this person who has local health director qualifications, they are the person who gets all those powers and authorities, right? So the ability to issue those isolation and quarantine orders, for example. But this is only going to apply to appointments that are made after August 1st, 2024. So as I said earlier, every CHSA has to be governed by a board, and there are two options. You can have an appointed board with up to 25 members, or you can actually have your Board of County Commissioners decide to serve as your board instead. Y'all have this model. So we'll talk about what this group of up to 25 people looks like. The statute actually gives us a list of professionals and community members who have to be represented on this board. And the law also says that the board composition must reasonably reflect the population makeup of the county. That's actually language that you see in all the statutes that apply to all the different types of local public health governing boards. There's no further explanation of what that means, right? We just get this, and then kind of counties interpret it differently. But that is in our statutes. Your members can serve 4-year terms, up to 2 that are consecutive, and if you have a county commissioner, which you do, they can serve for as long as they continue to be a county commissioner. So unfortunately, if they lose their election, they're no longer holding that county commissioner seat, they rotate off the board. You have a chair who's elected annually by your board. And again, all of y'all are going to be appointed by the Board of County Commissioners. When you are appointed, you're supposed to take an oath of office before you start exercising your official duties. I sometimes say that in front of boards of health, and I see these panic-stricken looks. So I won't make eye contact with anyone, but if you haven't done that, it's okay. There's still time, and it's not a huge deal. And I have a blog post all about it if you want to read about what you're supposed to swear to. And since the Board of County Commissioners can appoint you to a board, they are also the only body that can remove you from the board. But they can only do it for certain reasons, right? So if they say, Kirsten, I hear, is really disruptive in these board meetings. She's always going on tangents, she's driving folks crazy. We want to take her off the board. That by itself is actually not a reason to remove me, right, as a board member. It has to fall into one of these categories. So the Board of County Commissioners can remove somebody from the CHS board, but only for commission of a felony or some other crime involving moral turpitude, violation of a state law governing conflict of interest, violation of a written policy adopted by the Board of County Commissioners, habitual failure to attend meetings, which is not defined. We don't know how many absences constitutes habitual. Any conduct that brings the office into disrepute, and failure to maintain any of your qualifications for appointment. So for example, if you are the veterinarian on the board and your licensure is revoked, you can't serve as the veterinarian anymore. It might be possible to appoint you as a member of the public, but not in the veterinarian role. If the Board of County Commissioners does want to remove you, they have to give you prior notice, and they have to do so in writing. And then you also have to be given an opportunity to respond and kind of push back. There's not a lot in statute about what this process actually looks like, and I think in practice this comes up pretty rarely. But you do have an opportunity to know why you're being removed and to offer some type of counter if you think it's unfair. So let's talk next about public health. So the Consolidated Human Services Board, under this statute, again, your bread and butter statute where everything exists for y'all as the Consolidated Human Services Board, says that y'all will inherit all the powers and duties conferred by law on a Board of Health. And when it says Board of Health here, what it really means is a county Board of Health, because that's kind of the old school model in North Carolina, and that's what our statutes talk about, kind of at their core. So let's talk about the public health piece. So again, y'all as the Consolidated Human Services Board inherit all the same powers, duties, and responsibilities as your local county Board of Health. But there are also some public health powers and duties that get assigned to other players, like your Consolidated Human Services Director, the local health director, and also your Board of County Commissioners. Those sources of authority include statutes, so that's going to be anything that says GS with a number after it. Our North Carolina administrative rules, so those are things that are promulgated by agencies like the North Carolina Commission for Public Health. And then we also have case law, so whenever things are unclear, it goes up to our courts and they make decisions clarifying the law. So here are some things that are assigned by law to the Board of Health. And here, when I say Board of Health, I mean y'all, the CHS Board. One is this very general power and responsibility to protect and promote the public health. That's it. That's what the statute says. What does that mean? I don't exactly know, right? That's very, very broad. That covers a lot of different activities. But I think that makes sense in the context of public health, right? Because public health as a field is so expansive. Again, most boards of health will have the authority to appoint a local health director. Again, that's a little bit different in your consolidated model because that power is actually going to sit with your county manager. But the county manager does have to get the input and consent of this board. You can also adopt local rules as you see fit and necessary to promote and protect the public health. There are some restrictions on this power, and we're going to talk about that more in these next slides. But I talked a second ago about administrative rules, so things, for example, that the North Carolina Commission for Public Health might put out. So those might be rules, for example, about reportable communicable diseases in North Carolina. So we have a rule 10A NCAC 41A0101. It's a list of every single disease that has to be reported to the state and local public health agencies in North Carolina when a provider becomes aware of it. And that's necessary for public health surveillance. It applies all across the state. So local governing boards, so your local Board of Health, has a comparable power. And again, there are some restrictions on what you can do, but it's kind of the same concept, right? You can create a rule that applies throughout your entire county. You're also allowed to make policy for the public health department and adjudicate any appeals that come up, that arise out of those rules that you've created locally. So if you create a rule and you have a citizen who feels that they've been aggrieved, instead of going to a court first, they can actually come before y'all, and y'all can hear that complaint and make a decision as kind of the first round of adjudication. You can also impose certain fees for services. There are some places where fees can't really be tinkered with. That might be because you have, federal funding that says you're providing these types of cancer screenings. You're not allowed to charge more than X dollars per screening. Or you have a North Carolina law that says this is an STI test. You can't charge anything for it. But there are some places where you can set fees, and that particularly comes up in the environmental health space. There again are some restrictions around what those fees can look like, but you do have the option to help be part of that process in shaping what fees look like in your community. And then last but not least, the really, really fun part of local health department accreditation. So if you haven't been part of that before, you will have the opportunity to participate. So let's talk real quick about public health rules in a little more depth. So you also have a statute that says that the Board of County Commissioners can issue ordinances to address some types of public health issues. So what's the difference? Why do we have two statutes with seemingly comparable powers? Local public health rules are a little different. One, in that they apply throughout the entire county, including your municipalities. A Board of County Commissioners ordinance only touches unincorporated areas for the most part, right? It generally isn't going to apply in your cities and towns. They're also enforced differently. So you have different mechanisms for trying to enforce those ordinances and rules. We have a kind of general statute in 130A that says, for the most part, violating a local public health rule can be a misdemeanor. I think that's really distinct from how a lot of these local ordinances issued by boards of county commissioners are enforced. There are some places where you are not allowed to create your own local rules, and one of those is rules that pertain to the grading and permitting of food and lodging establishments. There's a really, really robust framework for this at the state level, and they've also, I believe, incorporated the FDA food code. So there's, hundreds upon hundreds of pages that applies to this area of law, and y'all just can't make your own rules locally. That's a statewide framework. You can, however, in the environmental health space, actually create your own rules that pertain to wastewater management, so things like septic tanks. But if you're going to do that, you have to be able to show to whom, typically to DHHS, that your rules are at least as stringent as their rules are. I don't think we have a lot of counties that have done this. I know Wake County has, but for the most part, I think most counties typically follow the state level rules. If you do want to make rules, there's a really specific, precise timeline. So I would encourage you as a board to consult with your county attorney, because getting all of those timeline pieces met is really important. And again, there are some limitations on what you can do in rules. So we have this case from 1996, and we don't have a lot of case law in this area, really just this and the next one that happened in Chatham County. But we get this set of requirements around public health rules locally. The first is that your rule actually has to be related to the promotion or protection of health. So you as a consolidated board cannot pass a local rule that says in all of Union County, we are going to raise and lower all flags at 8:01 a.m. And bring them back down to 8:02 a.m. every single day, right? Unless you can argue there's some nexus to health, that's not within your rulemaking authority, right? It also needs to be reasonable in light of the health risk addressed. So reasonable here means, looking at other options. Why did you land here instead of somewhere else? So making sure that it weighs well against the issue that you're actually trying to remedy. It, of course, can't violate any other law or constitutional provision. It can't be discriminatory in how it's enforced or applied. And it's not supposed to make any distinctions based on policy concerns that typically go to legislative bodies. So, for example, the General Assembly. Here we have another case that comes up in 2002, and this one is actually the one that I think we talk about more often when boards are trying to do rulemaking these days. This is Craig versus Chatham County, and it says, as a local board, if you want to adopt a rule that pertains to some type of public health issue that's already addressed in state law, you have to be able to show that there's something unique going on in your jurisdiction, so in your county, that necessitates that rule. And that can be kind of hard to do. But this is called implied preemption. We saw this come up a little bit during COVID-19 because sometimes counties wanted to create their own local public health rules, and they were struggling sometimes to articulate why their county was so different from the rest of the state that it merited their own local rule. And again, if you do decide to pass a rule, it has to be at least as stringent or more stringent than what the state has already done. Any questions about rules before I start talking more about the health director role? Yeah?
Do those rules coincide with I would assume that these rules would overrule anything that the school systems would do? I know sometime when COVID, for instance, was going on, sometime I'm not sure that the folks in the school system were compliant totally with the rules per se, or that were, that came out of the public health department.
Yeah, so the question was, do these types of rules, they, for example, kind of overrule a local school that wanted to do something different than what was required in rule? The answer generally is yes. There is another rulemaking body at the state level that can make rules related to education, and so it's possible you might have state rules related to education that could be in tension with public health rules, but generally the answer is yes, right? If it's about public health and it's a state or local public health rule, it's the law. And in North Carolina, we call these things rules. In other states or at the federal level, you would call them regulations. And so sometimes because we call them rules, they don't sound that serious, but they are laws. And that's why violating them can be a misdemeanor. So yes, they would typically trump. Any other questions? Okay. So again, we also have a health director. Health director in a county model would be the person who's in charge of your standalone local health department, but in a consolidated model, if they're not also the person who is the CHS director, then they're going to be the person who's typically tasked with public health duties and responsibilities and the kind of public health piece of the agency. So they have some responsibilities under statute as well, including administering all of the Board of Health programs and enforcing any rules that you also pass. They're required to investigate causes of infectious, communicable, and other diseases. They get to exercise that isolation and quarantine authority. They can abate public health nuisances and imminent hazards. So for example, if you have a space in your community that is really, really unsafe, it's creating a real public health threat, they have tools at their disposal that they can utilize to try and remedy that really quickly. They can also hire and fire their own health department staff, but again, this is not exactly true in a consolidated agency. You do have to get input from the CHS director and the county manager in that model. And they have all these other interesting responsibilities that are kind of sprinkled throughout 130A, our public health statutes. So for example, they are required to offer a rabies vaccine clinic. They're the ones who have to approve their jail medical plans for the county to make sure they're sufficient. They have a really unique access to records. So for example, if you're the health director and you are trying to investigate an outbreak of communicable disease, HIPAA is our federal health information privacy law, says if you have a state law that requires folks to turn over records, they have to comply with that. And so here in North Carolina, your health director can go to any HIPAA covered entity and say, I have a state law that allows me to get access to your records so that I can do my job of investigating this disease outbreak. And those entities are required. It's not a choice, they are required to turn over those records. And here we also have your Board of County Commissioners. So they have this kind of really big,
Can I ask a question on that?
Yeah, please.
So I know that's common on public places, but can we do that of someone that's like not the public school or something? Like if we have an outbreak, can you do that from someone that's like a charter school even, because it's owned by a private entity, even though it's a public charter? Do they have to honor the Public Records Act or FOIA or any of that for public health purposes?
Right, so communicable disease records, regardless of whose possession they're in, are not going to be public records under North Carolina law. They have their own protective statute. Schools can be a tiny bit different because they're sometimes covered by FERPA, and FERPA is actually a pretty inflexible law. There aren't a lot of pathways for sharing information. But if you're talking, for example, about public versus private healthcare providers, it does not matter.
So it's not excluded under the Emergency Management Act for that?
I honestly don't know. But if you're talking about Emergency Management Act, you probably have to have a declared emergency. So you'd have one more criteria that you have to meet. But yeah, so public or private providers, the law does not differentiate. It says you shall turn over these records if the health director says it's necessary. Any other questions about health director authority? Okay. One more thing I will say, we have exercise, isolation, and quarantine authority up here. There was some legislation in the last couple of years that slightly modified this authority and the parallel authority for the state health director. And I think during COVID-19, there was a lot of talk about this power and sometimes confusion around things like stay-at-home orders. In reality, you really don't see health directors using this very often, right? These are individualized orders that typically have to go out to individual people. They're pretty distinct. There's a whole process for appealing them through the court system if you're the subject of one. It's actually not a power that gets wielded that often. So just wanted to kind of demystify that power real quick. Yeah.
This may be semantics, but a couple slides ago you were saying that the board can't go against or be less stringent than a law. But mandates, law, same thing?
Mandates and law are typically going to be the same thing, yes. Is there like a specific context that you were thinking of that in?
I mean,
About COVID,
I
yeah.
mean, there's just mandates were put out, there was always a discussion, it's a mandate, but that's not a law. Is it a law or is it a mandate?
Yeah.
So how would that apply to that?
Yeah, so what would a board do? Yeah, COVID's a great example.
I mean, I don't know if it's just semantics in terms of the words, but
Yeah, sometimes it is and sometimes it isn't. It kind of depends on where the information is coming from. So during COVID-19, there, for example, was a lot of guidance coming from the federal level, from CDC, and a lot of it was guidance, right? It was not legally binding. However, we have some rules in North Carolina that are promulgated by the Commission for Public Health that incorporate by reference some CDC guidance that pertains to communicable disease control. And so they essentially say, this is best practice, that's going to be our law in North Carolina. So in that context, it really is a law. So it kind of depends on where it's coming from. In terms of what local boards can do, I've had this question come up a couple of times. Somebody wanted to know, for example, could their board issue a resolution endorsing a certain therapeutic for a disease, saying this is the best approach. I think the question there is, can you do it? Probably can. Are you going to give your county attorney a lot of heartburn? Yes, absolutely. Do you want to talk to them first? Probably. And so I think there are a lot of different things the board can do, but there is the issue of legal liability. And then sometimes beyond liability, there's also the issue of how does it impact your staff, especially when you're talking about public health and healthcare. Sometimes if you're handing down requirements at the policy level for your staff to do certain things, there are folks who say, I also answer to a licensing board, and this is my profession, and I can't, in good faith, do this and also maintain my licensure. And so sometimes you can also have things that aren't really about law, but that just end up being about staff and what people feel like they can and can't do for you. So we'll talk more about liability too in a minute. But this is actually a question that has come up a lot while I do these trainings. All right, anything else?
What did you say about ours refers to the best practice when guidance comes down, and it becomes law? What part of the statute was that?
Yeah, so we have a rule, a set of rules in North Carolina. It's in 10A NCAC chapter 41A. And those are our rules that set out the state's communicable disease control measures. So we have some control measures that are disease specific. So we have, for example, a rule that's just about syphilis, a rule just about HIV. I think Hep C gets its own rule too. And then we have some diseases where we don't have, a specific rule, in part because it oftentimes takes 18 months to create a new rule. And so instead of constantly trying to keep up with the science for every single disease and condition, we have a rule that says for other things, look at the CDC guidance, and that's going to be incorporated by reference and be our rule here in North Carolina. All right, we're going to talk a little more about the Board of County Commissioners then. Yeah, no, please.
Would that apply to something like the prevalence of fetal alcohol, or not unless that had been deemed a public health emergency within our state?
So the question was, would that type of rule
It's like the CDC has guidance on that.
Right.
That's
Would
not
that
what it
apply
looks like in
to
North
fetal
Carolina.
alcohol? Yeah. So I think the answer is no, in part because that set of rules is really focused on communicable diseases and conditions, and we actually have a list of those in North Carolina, and not every condition or disease makes that list. It's possible that you have other rules that do something similar and would look to another federal agency and incorporate by reference, but I don't know about fetal alcohol syndrome. Yeah.
Amy, kind of to tag on to that, one thing, I got tasked with rules rewrites for the Department of Ag at one point, and I asked my boss what I did wrong to get stuck doing that. And, I mean, there were rules that hadn't been updated since the early 80s that we were going back and reviewing. But a lot of times what we would do would be, if it was something that we wanted to keep in the rules, because nobody in Raleigh wants to open up code. They want to do it in the rulemaking process instead of the law. But we would refer back to the CFR for the federal regulations as often as we could in there. That way, if we needed the gray area, I guess, to be able to do our jobs, then it was, well, at worst, we're following the CFR. We're going to refer back to that. So, I mean, that was pretty common in how we tried to work through rules rewrites.
Thank you. Yeah, and that's especially common in the environmental space, not in the environmental health space and public health per se, but like in environmental space, like regulation of chemicals and things like that. A lot of referring back to federal regulations. And just a flag about rule readoption, we're not here to talk about that tonight, but there is a process in North Carolina called readoption. It's a new-ish process the General Assembly created about 11 years ago. And essentially every single agency in North Carolina that creates rules at the state level every 10 years has to go back in and update their rules. And the last time agencies had the option to kind of pull some of those rules out and say, these seem to be working for us, we're not going to revisit them. This time around, they don't have that option. So every single agency is either going to have to readopt their rules, which includes some really, really old rules that sometimes don't quite meet the requirements for rules these days, or they have to get rid of them. And that's actually going to be huge. It's going to be an enormous lift for state level staff, but it also means that realistically you're probably going to see a lot of changes in state level regulations. So just have that on your radar.
When is that?
It has already started. It starts 2024, and you can actually go to the OAH, Office of Administrative Hearings Rules Division website. And if they don't already have it, they will soon have a calendar that tells you which agency has to readopt their rules at which point in that 10-year process. Yeah. Okay. I don't want to keep you out here too long, so we'll talk about boards of county commissioners and then talk about the fun stuff, the liability, the public records, all that good stuff. So the Board of County Commissioners has this broad authority to organize government. That's why they're the ones who can say, we are going to consolidate in this county. They also get to adopt the budget, appoint members of your Board of Health, or in y'all's context, the Consolidated Human Services Board. And again, they also have some kind of general authority related to abating public health nuisances, but that's, again, only going to apply in unincorporated areas. And that's why sometimes folks will turn to public health instead and say, can y'all create a rule or have your health director step in, because you can take actions in other spaces where we can't sometimes. So other legal considerations, public records law. So FOIA is your public records law at the federal level in North Carolina. Doesn't have quite as cool of a name, we just call it public records law. It's in chapter 132, and it provides the public with the right of access to any and all records unless you can point to a specific exception that would make your records confidential or not public record. So anybody in North Carolina can make a public records request, and they don't have to say why they want the records, and sometimes they don't even have to say who they are, right? They might just have to give you an email address or some mechanism for getting the records back to them. So a public record is going to be anything that's made or received in connection with a transaction of public business. So that could be emails, it could be text messages, it could be interpretive dances, probably not, that'd be harder, but right, it can be so many different mediums and forms. And it's not going to include some certain things, again, that are carved out by law, so personnel information, things that might be attorney-client privilege are not going to be covered. But a really, really big point of confusion is that folks sometimes think that where the record lives is what matters. So folks will say, well, it doesn't matter. I had that conversation on my personal cell phone, so it's not a public record. That is not true, right? What you have to think about is this record related to a matter of public business? If the answer is yes, it does not matter where it lives. It is a public record, and you probably have a records retention requirement related to it. So we're going to go through a few examples here, and y'all are going to tell me if you think these are subject to public records law. Our first one here, we have a board member who uses her personal cell phone to text the board chair with thoughts about an upcoming meeting about environmental health fees. Do y'all think that's a public record? Yes. Good, you guys are not so easily tricked. All right, next one, we have a board member who uses their personal Yahoo email address to respond to a question from a Board of County Commissioner member about the agenda for the next meeting. What do we think? Yeah. All right, last but not least, you have somebody here holding you late, and you are using your county-assigned email address to email your wife and say, I'm running late, I'll be home in about an hour. Is that a public record? Y'all are doing great. Awesome, so you're right. So these first two, even though you're using personal devices or personal email addresses, because they're about public business, they're going to be public records. The one at the bottom, you're using your official county email, but you're not talking about public business, right? That's probably not public record. So if you get a public records request, either as an individual board member or as the board, strongly encourage you to loop in your county attorney. That is just because it's not always clear who's considered the custodian of records, and you probably want some help figuring out what you're actually required to turn over by law. And that's because sometimes you might accidentally turn over things that you don't have to, or things that are even confidential and protected. And then sometimes you can turn over too little, or maybe take too long, and that can create some issues as well. So you really want to loop in legal counsel when you can on this. We don't have a specific time frame for how fast you have to turn over records, except that it has to be reasonable and as prompt as possible. And that really just depends on what the ask is, right? If somebody's asking for 20 years of records, this might take a few years, and that might be totally reasonable. If they're asking for 2 emails from 2 days, 24 hours, 48 hours a week might be what you're looking for. You also have record retention requirements, which I'm going to talk about very, very briefly. But just know that if you are sending emails or text messages about public business, about your work on the board, you may have a requirement under law to retain those, to not delete them. If you want to know more about what exactly you're supposed to retain and for how long, you can actually go to the North Carolina Department of Natural and Cultural Resources website, and they have what they call a retention schedule. It's like a thrilling 60-page document that tells you piece by piece what you have to keep and for how long. Your open meetings laws. So you are all, as an entity, as the board, subject to open meetings in North Carolina, and you know that you are holding an open official meeting when you have a majority of members coming together. So if you have every single seat on your board filled, that'd be 13 of y'all. If you have 20 or 19 filled, right, it's a smaller number. If you are gathering together in person or electronically, so if you're meeting over Zoom, that still counts. And your goal is to conduct a hearing, deliberate, vote, or otherwise talk about some type of public business, and you are having an official meeting. So what does that mean? It means the public has to get notice of your meeting, right? They have to have an opportunity to learn about your meeting so they can show up if they want to. They also have to have access. So that means that, for example, if you are streaming the meeting, they have to be able to join that somehow. But it does not mean that you have to have a public comment period. I think this is a really common misconception. You are not required to take public comments at every single meeting. If you're going to do rulemaking, there is a requirement for public comment, but otherwise, you don't have to. You also have to keep meeting minutes, and you can have closed sessions in limited situations. For example, if you're talking to your attorney about some type of privileged information. All right, let's roll through these real quick. So, is this an official meeting? First, we have 2 members of your board who get together for coffee, and they discuss the local school football team's latest game. What do we think?
No.
So say no. Okay, great. We have a slightly different scenario. The same 2 members get together a week later, and now they're going to discuss ideas for a new local public health rule.
Yes.
Ooh, but it's just 2 of them, right? Think about that numbers issue.
How many?
Right. So it's how many of y'all, and why are you getting together? So then we have the entire board. Y'all are going to get together at the chair's house. Sorry, just invite everybody over to your place for dinner, and during that, you guys are having dessert. You weren't talking business at all that night, but during dessert, you start talking about changing the fees for pool inspections.
Yes.
Yeah. All right, and this last one, you have 11 board members, 2 county commissioners, and 3 representatives from a local hospital. Y'all are going to get together, talk about some wonderful new plan that will connect first-time parents of premature babies with home nurse visiting services. What do we think? That one's a little bit of a trick question. So the first 2, no, right? The first one's very easy because you don't have enough people getting together, and you're talking about something that's not related to your duties on the board. The second one, you are talking about board-related work, but it's just 2 of you, right? So you're probably not getting anywhere near that quorum that would trigger this issue. The last one, even though y'all got together to have a nice time, no business talk allowed, but during dessert you slipped into talking about pool inspection fees. Now you are having an official meeting, so everyone needs to stop talking, at least about pool inspection fees, and if you want to have that conversation, again, you have to notice it and follow the proper procedure for it. This last one is really hard, and that's because you have 11 board members, but you also have some county commissioners, and so you have folks coming together from different government entities. You don't have quite enough people for a quorum for your board, your consolidated board, or your county commissioners, but you have enough government folks coming together that there's a question of whether or not, since you're talking about government business, whether or not that should really be an official meeting. So I would say consult your attorney if you have questions. Ethics and conflicts of interest. just the big one here. It does not have to be illegal for it to be unethical or just a bad idea. Sometimes we talk about the newspaper test. If what you're doing were to be on the front page of a newspaper, would it make your organization look bad? If the answer is yes, it's probably unethical, even if it's not illegal. We have different statutes in North Carolina that address different types of conflicts of interest and ethical issues. You'll notice that we have two here that are in GS 14. Those are our criminal statutes, and that's because these can have criminal consequences if you get tangled up in them. And last but not least, liability and immunity. So as board members, you can be sued. And you can be sued in your official capacity and your individual capacity, and worst case scenario in both. Oftentimes folks who are trying to sue will take a pass at doing both because they're kind of throwing everything at the wall to see what sticks. Official capacity means that the lawsuit's actually against the county, right? It's going to be so-and-so versus Union County, not against the Consolidated Board, but the county, because the county is the legal entity. Individual capacity means that it's against you, personally, as the board member. In good news, though, y'all do have some protection from liability, some types of immunity. So we have one thing here called governmental immunity, and that's for certain torts. If the thing that you did that somebody is dissatisfied with was related to governmental functions and the local government didn't waive their immunity, you might be covered by this. And then you also get public official immunity. This does not, however, cover intentional torts like battery. So if you get into a fight with somebody at one of these meetings and you punch them, you're probably not going to be covered, right? It's probably outside the scope. But it does cover things like negligence. It does not cover malicious or corrupt acts or any acts outside the scope of your duties. So if you as the board start doing something that is really, really out of left field, right? And it's really beyond your duties as the board, this might actually not cover you anymore.
Excuse me. Yeah. Can you give us a couple examples of how some of the board members could be sued? To make sure we do.
So with more examples, I will be totally candid and say that Christy Nicodem is actually our queen of liability. So she can probably give you better examples in September than I can. Obviously, one would be something like punching somebody at one of these meetings. Another might be if y'all pass a rule that somebody thinks is unconstitutional. They could try and sue you for that. Whether or not they'd be successful, I think, is another question. Yeah.
The one that I actually thought about after one of our dangerous dog hearings was where we've recommended a dog be considered a dangerous dog, and then there's rules that they fall under.
Yeah.
And the person is not happy with that decision.
Yeah.
Can we, if we had reason to make that decision, can they sue us for it?
Yeah, so that's a great question. So there's, I think, a distinction between can somebody sue me and will somebody succeed in court?
Yeah.
And the answer is people can sue you for almost anything, right? Whether or not it's actually going to get very far is a totally different question. Whether or not they can even find an attorney who's going to take their case, totally different question. But will they succeed? There, if you were within the bounds of the law, this was something that you as the board are tasked with doing, you have good reason for it, you are probably going to fall into one of these categories, right? You can back that up. If it was totally outside the scope of your duties, or you were being really reckless, I mean, just the recommendation made no sense. Or you were, for example, favoring a cousin of yours, and that's why you got the entire board to side with you and not recommend that dog, have X, Y, Z. That might be a different situation. But if you're really backed up by law and facts, and this is within the scope of your duties, it's often going to be hard for folks to succeed in suing you.
But in a case like that, if the person who had brought it forward accused us of negligence, right, for not addressing the issue, then they would have the grounds for suing on the liability, right? Like if the dog went on to do something.
Right, they can certainly sue you. I think the question is, will they succeed? And typically the burden's going to be on them to show that you actually were somehow negligent. So, yeah, that's always a fun, light part to end on. But with that, I will say we have lots of resources for you here. And if you have questions, you're always welcome to give me a call. My expertise is really public health law, so if you want to talk about social services or immunity liability, things like that, Christy is really fabulous. She's also done some really great work around the First Amendment. So if you have questions about members of the public who come to your meetings and kind of the scope of what you are and aren't allowed to do when folks might be a little rambunctious or really enthusiastic about participating, she's a really great resource for that as well. So.
Yeah.
Thank you so much. I can't wait till part 2. Anyone else have any more questions? Okay. Janet, can we have what's next to do? Oh, the fees.
Yes.
So Dennis?
Yes, we have one new RSV vaccine fee that we have on the agenda. This is establishing the fee. This is fairly new vaccine that's been approved. I'm going to let Ashley, I do know who the nursing director is, I'm sorry. Ashley can share the context of the vaccine.
Yeah, it's for the respiratory syncytial virus. It is for women who are between 32 and 36 weeks of pregnancy. It's recommended. And also, I'll just stay on top, sorry. And also for people 75 and older, anybody, and then people that are 60 to 75 that have certain medical conditions.
And so this is establishing the fee at our usual fee setting, following our fee setting policy, which typically in this case looks at what the Medicaid reimbursement rate is, plus 30%. Obviously, this is not going to be one that's going to be super popular because it's very pricey. But we do need to have this added to the fee schedule.
Why did you say it wasn't going to be popular, Dennis? I kind of missed that.
It's because it's not, there's nothing else covering it, and the cost of it is $394. We're setting the fee at $394. It's just an expensive vaccine in general.
So it's just something that we have to have available to offer?
As part of our participation in the Vaccine for Children's program, we have to have it available.
Is this something that's standard, or is this something like if for premature, like if you're expecting someone to go premature, or like it's just a...
The standard would be to receive it between 32 and 36 weeks of pregnancy, with the intent that then the baby would have passive immunity from the mom. If that can't happen and mom can't get it at that time, then you would want to give it to a baby born, during RSV season.
The same vaccine?
It's Fortis is the other one that the baby would get.
What's the cost of the one the baby gets?
There's state provided vaccine for that, so
zero.
babies that come are going to get it. If they don't have a payer source, then they get it.
I'm just curious.
Yeah.
Is this a new virus, or is it
I know RSV
has been around.
Oh, it's RSV, okay.
RSV.
The first word threw me off. Yeah, I know RSV is, okay, the A word threw me off.
RSV.
I'm sorry, I asked a question now. But thank you. I know what that is, thank you. Okay, that's the name of the, okay. Perfect, thank you.
So Medicaid would cover these for those eligible?
It would, yes.
Just for others? Okay. Any other questions, board members, about this particular vaccine?
How do y'all decide which ones have a sliding scale and which do not? on like a fee sliding
It
scale?
depends on what clinic they're given in. If it's a child health clinic patient and they're receiving vaccine in that clinic, then it would slide. If they're in our immunization clinic, then it would not slide.
You said most health insurance will not cover this vaccine?
Health insurance and Medicaid
Okay.
would, and Medicare.
Okay, do we have a motion for this, fee for this, vaccine?
Second.
Okay, all in favor say aye. Any nays? Okay, approved. And we don't have any public comment today, do we?
But we may have to just.
Oh, just right, that's right. Okay, division updates.
I'll go ahead and start. The only thing I want to mention is just some folks may have heard that we had an example of what Kirsten was talking about with the communicable disease reporting system, where it actually worked as it relates to a TB case that we had, and we've been following Porter Ridge in a student. And we found out about that from a provider that told us about it. It's positive active TB. And it also came through the electronic surveillance system as well. So we received it both ways. So I just wanted to share that the issue of communicable disease and the reporting actually does work sometimes. And in this particular case, we were able to make contact with the individual and the family and have been doing follow-up with them. Obviously, they are the most closely at risk for TB. And we did also have to communicate to around 270 students and at the school, and that communication went out, and we did do a public news release just because we wanted to get ahead of the story so folks understood. They heard it from us first versus hearing it from somewhere else. And we're in the process now of following up. The main message is for those folks who were exposed, and we worked with the school health nurse staff to make those determinations. They're recommended to be tested for TB, and its risk is still low, for the most part, but hopefully we'll get folks in to be tested, and right now the students being treated, compliant, everything's going along well. Ashley, as far as from that standpoint, everything's is going well. And it would not surprise us, even in the testing, if we don't pick up some latent TB. That's common. If you test enough people, you're gonna find latent TB. That's not the one we're concerned about.
Do you know where he got it from, or she?
No, we don't. Some past exposure. Yeah.
And that was during the summer, and you had to reach out to 270 something. Right?
Yes, it was, but you have to go back quite a ways. So we were actually the two pools of folks were, because you're going back 8 weeks, 3 months. Okay, 3 months back from the time of initial exposure. So that would have put them in school. They would have been back in school, but they had also gone to summer school. So that added another pool of folks to have to assess. But anyway, I just wanted to make folks aware of that, and it seems to be going well right now for that particular case. I don't have anything else to report.
Dennis, I wanted to ask you a question. It seems like in the news somewhat that in hearing about COVID come up again. So I know you were measuring or having reports about wastewater. What's happening in Union County versus based on just hearing about COVID coming alive again per se?
Yeah, well, it never really went away. It's going to be with us for a long time, like the flu and other things. It's no longer reportable. We're not under emergency declaration, so it's not a reportable disease. So we track that and monitor that sort of using other parameters and other proxy measures, and that being wastewater surveillance is one way North Carolina is monitoring that, and we've heard us talk about that. And we have seen across North Carolina increasing evidence and volume of wastewater detection of COVID. And the fact that you hear of friends or people that are at, work or wherever saying, I know somebody got COVID. I mean, we hear it all around. Yes, it is. It's out there, and it is. We will see these waves where it peaks. The problem is we can't be as precise in following those waves. We're having to kind of do it from looking at these surveillance models that we have. The other is, and in many ways the more, well, I'm not going to say more important because they're both important, but is looking at hospital use and particularly folks who may be hospitalized as a result of COVID or have complications associated with COVID. And pretty much across at least North Carolina, that has continued to stay fairly low. So that's the good thing. It's not that we're seeing extreme impacts of it in terms of serious illness and death. So that's sort of my take on it. It's that we're going to continue to see it. We'll ride these waves for quite a while. I'm just glad you didn't ask me what strain we're on right now, because we've gone through probably, 15 or 20, and they're using a whole new alphabet now for it. So, but it's going to evolve and it's going to change, and hopefully it remains relatively mild. Unless you have it and you're sort of sick for a few days and wonder,
Thank you, Dennis. Thank you.
So test? It's on. Can you hear me now? I have a few updates from DSS. So for the past several months when we've been meeting, not in July, I have spoken to the fact that DSS is a huge department and are always in need of staff. I have some very exciting, happy news to share with you. Since I'm always begging for staff, I want you to know kind of where we're at. And in our 3 separate buckets, what I just talked to our new folks about, when you think about social services, in our first big bucket of social work, we are only short 3 workers out of 103, and that means we are 98% staff. That, I want y'all to give me a hand clap, because that is really hard for DSSs across the state. I mean, it's hard for everybody. She spoke to the staffing shortages we're seeing in mental health. It's happening everywhere, from public health to social services to everything, so that. In economic services, Earl used to run our economic services program, for those of you who are new. He did a fantastic job at it. We are currently only short 7 out of 125, which means we're 95% staffed. And then our behavioral health collaborative is small but mighty. We have 31 staff there, and we're short 2, which puts us at 94% staff. So I'm super excited to share that news with you all. I feel like I'm always telling you how much of a need there is, and there still is a need. I need to fill those last vacancies, and there will be some turnover throughout the year, but I'm very excited to share that things are looking really good right now. A big project that we're kind of working on the down low, but I wanted to share with you all as the Human Services Board, is the fact that we have always, according to me, because I've been here 6.5 years, but for the past, let's say 15 to 20 years, we've owned a group home. We used to operate it through social services, and then around 2019, we decided to contract that out to Department of Juvenile Justice, who sublet it to Methodist Homes, and they would run it. And we had one emergency bed for emergency foster care placements that we would be able to place there. COVID hit. We lacked placements across the state, and we started to struggle really bad with finding placements, especially treatment options for foster youth who needed a higher level of care than just foster care. So we decided to rethink how we were operating that program. We pulled that back from DJJ, and it's currently sitting vacant. And we are in some pretty good talks with Partners, who is our local LME MCO, and we're in talks with Cabarrus County and coming up with a collaboration along with Alexander Youth Network. And so I wanted to just give you all a quick update on that and let you know the talks are going really well. Alexander is committed to helping us come up with a better solution for the youth in Union and Cabarrus County. So there'll be more to come on that. Other thing that's of vital importance is since December, we started Medicaid expansion all across the state of North Carolina. I wanted to give you a quick update on that. And if you ever want to look this up on your own because you're just so excited about it, the North Carolina Department of Health and Human Services has a Medicaid enrollment dashboard. If you just put that in and Google it, it'll pop up. But for Union County, we have added 7,587 new enrollees into Medicaid expansion. And just some numbers for you on that, 32% of that 7,500 are between the ages of 19 and 29, and then 30% are between the ages of 30 and 44. So our biggest cluster is that kind of younger adult population that typically, before Medicaid expansion, didn't qualify. These are your folks who are working jobs that don't offer health insurance through their employer, or they just simply can't afford it because health insurance costs so much. So I just want to share those updates for you all.
Thank you.
They have a mic down there. Yeah, sorry.
Okay. Well, it seems like that's all of the division reports. So, can I get a motion to adjourn?
Motion to adjourn.
Got a motion to adjourn? Got 1 year? This week.
Second, third, fourth.
All approved, saying aye. Opposed?